Hey, and welcome back to the part 3 of our chronic conditions session. So this is the last part of this PowerPoint presentation. So it was definitely too long to put into one recording. It has 177 slides. So this one we're going to be focusing on pain, chronic pain, endocrine, hematological emergencies, as well as immunological emergencies as well. So we're going to try to get through this material and finish up with chapter 15. So as you all well know, pain is one of the most common reasons that people call 911. And for community paramedics, it's the most complex thing that we can help manage. So pain isn't just physical, it's emotional, psychological, and social. So in our area, many of our chronic pain patients are older adults who lived with arthritis, neuropathy, or injuries for years because of labor. They often don't need emergency transport, they just need connection, education, and consistency. So when you're assessing pain, take the time to listen and ask how it affects their day-to-day life. You'll learn a lot more than with a simple number on a pain scale 1 to 10 can tell you. So for our IBSC exam, expect a question about differentiating acute versus chronic pain. They usually like to hit that pretty heavy. Chronic pain, as we know, lasts longer than 3 to 6 months and often requires ongoing management, not emergency intervention. So moving on. So our pain patients can be classified, or pain can be classified by duration, the cause, or the type. For example, we may see acute pain after an injury for surgery, while chronic pain lingers beyond the normal healing time. In the community setting, understanding the pathology-based pain, like neuropathy or neuropathic pain or an inflammatory pain, helps us know when to escalate care or just adjust the support that we are given. In Henderson County, a lot of patients suffer from degenerative joint pain, diabetic neuropathy, or post-stroke pain. Knowing which category that pain falls into helps you make targeted recommendations and communicate clearly with your primary care team. So just keep in mind there's also different types of pain that you will need to be able to recognize and identify for testing. That would be somatic, visceral, or neuropathic pain based on the description that your patient gives you. There are 4 main types of pain: physiologic, somatic, visceral, and pathologic. So physiologic pain is your body's normal reaction, like you pull away from a hot surface when you touch it. Our somatic pain is that is muscle, bones, joints, think arthritis or fractures. And then our visceral pain comes from our internal organs, our gallbladder or our bowel pain. Our pathologic pain results from disease or nerve dysfunction. In our community, you're going to see a mix of this, from post-op pain, from orthopedic procedures, hospital things, to long-term visceral pain in patients with chronic pancreatitis, or IBS. So recognizing these patterns helps you tailor your education and the referrals that you're going to get for your patients. When assessing pain, look beyond the number, ask where it hurts, what makes it better or worse, and how it impacts their daily living. So observe their posture, their facial expression, are they guarding, and their mobility. For chronic pain patients, transportation challenges can often mean they're not seeing their provider regularly. This is where we step in and make a difference. We need to document changes, reporting trends back to their care team. So with our IBSC, expect scenario questions that test your ability to perform a full pain assessment using subjective and objective findings. Always use location, duration, quality, and the impacts on the ADLs. And remember, ADL stands for Activity of Daily Learnings or Livings. So monitoring is all about consistency. During follow-ups, ask the same questions, use the same scale, and compare to prior visits. If the pain's increasing, dig into why. Maybe they ran out of their pain meds, they couldn't afford it, or they're having issues even opening their pain medication. Or maybe there's a new underlying issue that you've not yet hit. Locally, we often see this with patients living alone. We have very rural areas in western North Carolina, like Edneyville, Dana, Sunnyview, Girton. So they may be rationing those medications. Encourage them to communicate with their provider instead of toughing it out. So know how to handle conflicting information between your assessment and the physician notes. So always document objectively and communicate findings through the proper medical direction channels. Management starts with addressing the cause. For example, if the pain is due to poor mobility or inflammation, we might reinforce gentle exercise, hydration, or even assistive devices. As CPs, we don't prescribe, but we can review medication adherence, check for side effects, and make sure patients understand the dosing instructions. So we do have some community partners locally, Blue Ridge Health or the free clinics, which we learned a lot about. They can help patients access affordable medications or therapy referrals. So make sure we know our scope of practice. Management for CPs focuses on education, support, and communication, not direct pharmacological or pharmacological changes. Education, our patients need to know that complete relief may not be possible, but quality of their life can still improve. Teach them pacing, relaxation techniques, and the importance of staying active within their limits and what that looks like for them. In our own region, we have chronic pain patients that we may be able to send to Four Seasons Palliative Care, or even Via Health may have some multidisciplinary support. When we walk into a home, small encouragements like acknowledging their progress or validating their frustrations can rebuild trust in the healthcare system. So with our testing, watch for questions about patient education and self-management goals. The right answer usually involves realistic expectations, collaboration, and empowerment rather than promising a cure. Diabetes for endocrine is what we're going to start off with. One of the most common chronic diseases we see, both nationally and then right here in our own backyard. It is a condition where the body either doesn't make enough insulin or doesn't use it effectively. Remember, insulin is the hormone that lets glucose and other nutrients cross into the cells so the body can actually use them for energy. When that system fails, sugar stays in the bloodstream and begins to damage vessels and organs over time. That's where we see complications, our microvascular diseases, neuropathy, poor circulation, stroke, and then heart disease occur. In women, diabetes can also appear with menstrual irregularities or even yeast infections and sometimes polycystic ovarian syndrome. For us in community paramedicine, our goal isn't just to recognize the hyperglycemic crisis that's late in the game. Our goal and our role is to ID and educate, noticing the small things like frequent urination, constant thirst, unexplained fatigue, or a wound that's just not healing. Diagnosis is made through testing. The HbA1c tells us the average blood sugar over the last 2 to 3 months. It is the best indicator of long-term control. We also look at fasting plasma glucose or random glucose test. If that random reading is over 200 and the patient has symptoms, that's diagnostic for diabetes. Nationally, about 9% of the U.S. population has diabetes. That's around roughly 29 million people that have been diagnosed, and many more are undiagnosed. It is the 7th leading cause of death and cost over $170 billion every year. Here in Western North Carolina, those numbers are even higher because of lifestyle and access issues in our rural areas. Type 1. So type 1, they used to call it juvenile diabetes. So that is an autoimmune disorder. The pancreas no longer makes insulin. These patients usually present early in life. Our type 2 usually develops later on and is tied to obesity and inactivity. It's what we most often see locally. In Henderson County, type 2 diabetes rates are higher than the state average, particularly in our rural areas like Green River and Edneyville being some of our hot spots. That's why outreach programs from Blue Ridge Health are such an important partner to us. When you're following up, review their meds, their metformin, their insulin, or their GLP-1s that they're even taking, and make sure they're using them correctly. Monitoring isn't just about checking the sugar reading, it's about watching for trends. Low energy, confusion, poor wound healing, looking at their skin, their hydration, and their diet habits. Here in the community, we can catch early signs of neuropathy or infection before they become hospital visits. If you notice chronic swelling, poor circulation, or ulcers, that's your cue to escalate to their provider and bring those findings back to them. Foot exams, got to get good at the foot exams. They are huge. Up to half of our older adults with type 2 diabetes are at risk for ulcerations. So check for sensation, or calluses, redness, or skin breakdown. In our area, a lot of patients wear improper footwear because of limited income. So they have to kind of go with what they can afford, or they pick up used shoes from the Habitat thrift shop. So connecting them to the free resources is key. So free clinics might also be one that could help with this, or some vouchers maybe from the Habitat for Humanity Restore. That would be a good way to start. But always remind them to inspect their feet daily and report anything new immediately. Management is all about prevention. controlling blood pressure, glucose, and lipids. Encourage small steps, eating fresh produce from local markets, walking at Jackson Park, staying hydrated, not smoking. The exam may ask interventions or what intervention best reduces vascular complication. That's going to be lifestyle modifications and glycemic control, not high-dose insulin. So our education looks different for every patient. Some need help understanding what A1C means. Others need visual guides for carb counting. Emphasize that diabetes isn't curable, but it's manageable. Show them small changes like portion control or checking sugars before driving can keep them safe. Locally, Henderson County Health Department runs a diabetes wellness program. Woot woot. That's a perfect resource for referrals for you all. All right, on to our common hematological and lymphatic conditions. Sickle cell is not one we commonly see in Western North Carolina, but we may encounter some patients from surrounding areas. The main focus is hydration, as well as infection prevention and then pain control. Hepatitis, however, is rising, especially Hep C, among those with past IV drug use. As CPs, we can educate on transmission, safe practices, connect them with treatment programs through VIA Health or the free clinics. Be ready to identify educational versus clinical responsibilities. So especially for testing purposes, CPs are going to teach and coordinate. They don't diagnose or prescribe any antivirals. There are complications that could reoccur from sickle cell. That could be recurrent bacterial infections, stroke, kidney failure, chronic pain, pulmonary hypertension as well. So it is thought to affect about 100,000 people in the United States. Majority of these people are African Americans, and 1 in every 13 African American has a sickle cell trait, in case you did not know that. Patients with sickle cell anemia should be closely monitored for appropriate hydration and diet compliance. Management includes techniques to prevent sickle cell crisis, such as hydration, make sure they're using their medication, the hydroxyurea, blood transfusions, or bone marrow transplants. Some patients with sickle cell disease may have other issues such as chronic pain. Prepare patients for the possibility of these such conditions to occur. Community paramedics should take time to assess the patient's level of understanding of the disease that they have. Patients with this disease should maintain good hygiene, learn to recognize what has caused the exacerbation in the past. This disease will progress, so the patient needs to understand how and when to seek assistance for those emergent situations. So here's our hepatitis. So it is on the rise, as we saw in our county. It is an inflammation of the liver. It is something we occasionally see. So we may have follow-ups here in Henderson County. The most common cause is a viral infection, but remember it can also be a result from alcohol use, IV drug use, and certain medications or even autoimmune conditions. When the liver becomes inflamed, its ability to filter toxins and process nutrients and produce clotting factors is impaired. That's when patients start to show those symptoms like jaundice, fatigue, abdominal pain, sometimes confusion if we have too much of a toxic buildup. There are several forms of hepatitis, but the viral types, that's A, B, C, D, and E, are the most concerning. Community paramedics most often encounter Hep C, especially among those patients with a history of IV drug use. It's transmitted through blood and other body fluids, and that makes harm reduction education crucial in our area. Here's an important point. About 15 to 25% of people who are exposed to Hep C will clear it naturally without treatment. But for the rest, the infection becomes chronic. And over the next 20 to 30 years, 5 to 20% will develop cirrhosis of the liver. Cirrhosis is serious. It means the liver has been scarred to the point that it cannot recover. When that happens, the patient condition has reached an advanced, often terminal stage. Another major complication is hepatic encephalopathy, which occurs when the liver can't remove toxins from the blood. You'll see confusion, tremors, or even altered consciousness. While it can be reversible, if treated early, it's life-threatening when missed. For us in community paramedicine, the focus is on education and connection. We reinforce medication adherence, emphasize hydration and nutrition, and help patients avoid alcohol and drug that can worsen liver injury. When we see warning signs like jaundice or mental status changes, we communicate that quickly to our medical director. There's an IBSC tip. So the exam may test your ability to identify when education and referral are appropriate versus when a patient needs immediate transport. Remember, hepatic encephalopathy or worsening jaundice are red flags, and those patients require urgent evaluation. And locally, you can refer patients to the free clinics or Via Health. They have a substance use navigator program for Hep C management as well as support. So monitoring these patients with hepatitis, they may have many common physical signs that may indicate further progression or aid in staging in their disease. We're looking for yellowing of the skin or the sclera of their eyes with that jaundice. Their hepatomyalgia, when an enlarged liver, may be palatable, so you can actually palpate it during your physical examination. So noted in a diagnostic test such as a computer as well as an x-ray or something like computed topography or an x-ray. So they may have paperwork from their most recent doctor's visit that notes that they may have some enlarging of their liver that is occurring. Management is primarily supportive and seeks to prevent complications. If patients demonstrate any red flags such as altered mental status, we're going to alert the medical director. Many patients will have chronic nausea, or they may have intertraceable vomiting. That needs to be addressed with hydration and correction of electrolyte imbalances as well. So that's where some IV therapy may come into play for you guys. Patients with hepatitis are immunocompromised. Do not place them in danger of infection more than necessary. So follow the patient's plan of care and always adhere to your local protocols. So education is focusing on improving their understanding of the causes or the exacerbations of their conditions. It's especially important with patients who exacerbations occur secondary to alcohol intake or sodium intake. So we need to limit our daily sodium for these patients to about 2 grams a day. Patients also need education on how this disease can be spread. On to obesity. This is defined as an excess of body fat caused by an imbalance between caloric intake and expenditure. So in simple terms, more energy is coming out than is going out. So here in Henderson County, we see that every day. There's limited access to fresh food, long work hours, sedentary lifestyles. These all play a role. Many residents rely on processed or fast foods because of convenience and cost. As CPs, our goal is not to lecture about the weight, but to understand the full picture: diet, mobility, medication side effects, and their mental health. When we monitor obesity, we need to be looking at trends: the weight, their BMI, the overall wellness. But remember, BMI alone doesn't tell you the whole picture, it doesn't tell you the whole story. Muscle mass, body type, and fluid balance also all play a role. Many obese patients also deal with comorbidities like hypertension, diabetes, congestive heart failure. During our home visits, look for things like shortness of breath, swelling, pitting edema, or any mobility changes. Ask those open-ended questions like, what do your meals look like? Or how active do you feel on most days? That's where you'll uncover barriers like depression, lack of transportation, or even the fear of falling. Locally, we can refer patients to Blue Ridge Health. They have a weight management program, or Party also has a hospital's nutrition counseling services that's set up for long-term follow-up as well. Management is about practical, realistic steps, baby steps, not crash diets or guilt trips. Encourage patients to start small. Just drink more water. Replace 1 soda a day with 8 ounces of water. That could be a baby step. Cut back on sugary beverages by that. We can add 10 minutes of movement daily. Maybe add a trip down to the mailbox and back. Here in our area, we can leverage our community spaces, and most places do have different parks that they could set up and they could go to for their walking trails. Or YMCAs, they have a Silver Sneakers program or different classes. There's different extension programs like Eat Smart, Move More. That might be a good incentive for them to sign up for. These options are accessible and they're also very welcoming. Explain that sustainable weight loss, just 5%, can drastically lower the risk of diabetes as well as heart disease. Help patients set reasonable goals with measurables. Short-term goals lead to those long-term goals. And the long-term goals is when we start seeing those big results. Education should focus on empowerment, not shame. When talking about diet and exercise, use plain language and encourage accountability. So what's one thing you feel confident you can change this week is a good way to start. Many of our Henderson County patients lived on fixed incomes. We need to show them realistic ways to eat healthier, like buying frozen vegetables, attending local food banks. They have produce days, visiting farmers markets with SNAP So some of our food stamp programs actually do have SNAP incentives, so you can actually get perks for getting produce. Connect patients with programs through Cooperative Extension or our Council on Aging. They provide meal prep classes and nutrition guidance. For exam purposes, remember that the community paramedic's primary role is education and navigation. We're not prescribing diets or exercise regimens. We're going to guide, coach, and connect them with resources that will help them thrive. When it comes to medical technology in the home setting, this is a big one. There was several testables on the IBSC exam, particularly the types of things that we use to move patients in a home setting. So our role here is to make sure patients understand how these devices work and that everything is functioning properly and that they will know what to do if something fails. So in Henderson County, many of our elderly patients rely on home oxygen or CPAP or infusion pumps. So when Hurricane Helene came through, we had multiple requests for more O2 tanks or regulators because we had no power to provide for any of these things. So we needed to know where our sickest, where our chronic disease patients lived in the county so we could very quickly gain access to these patients and give them the things that they needed in their home setting. So do visits every time you do a visit, do a quick equipment check. Check their power supply, their tubing, make sure their tubing isn't stretched all through the house and then back around and underneath grandma's chair and up again. So check their tubing, explain why long tubing is bad. Check the cleanliness and the patient understanding of their equipment. If you find something outside of your scope of practice, document and escalate to the medical director or the home health agency. All right, let's talk pacemakers. You guys all know what pacemakers are. They're internal devices that regulate our heart's rhythm. They're common among our older adults, especially those with AFib or the ones that have heart blocks. Always note the pacemaker type, the last follow-up, and any symptoms such as dizziness or fatigue they may be having. If a patient reports a fluttering, filling, or near syncopal episode, that may indicate malfunction or battery depletion. Locally, Party Hospital and Advent Health Cardiology can both handle these device checks, so help coordinate those appointments when they are needed. Our wearable cardioverter defibrillators are WCDs. I honestly have never seen one of these in the field. I know they are out there. I know they're actually in our region. They're not as common. So you may see these in post-cardiac arrest or post-MI patients discharged from Mission Hospital or Part D. So ensure the device is charged, it's fitted correctly, and that the patient understands its purpose. Some patients may be anxious. I would be anxious. Reassure them that this is a safety net. This is something that's going to help if their heart does give out, and it's not seen as a punishment. So check for compliance and comfort with these things. Some patients stop wearing them because they're bulky or they're irritating. Encourage consistent use, especially at night. A missed wear could mean a missed life-saving shock. So IBSC exam tip. On the exam, expect questions about patient compliance and device troubleshooting. Look for answers emphasizing assessment and education within your scope. Common theme. Onto our VADs, ventricular assist devices. VADs partially or completely take over the work of the ventricles. Most often our left, being the largest. These patients are complex. They often have heart failure and are not wanting to, they are waiting for a transplant or for long-term management. If you ever encounter a VAD patient, remember they may have no palpable pulse, even when perfusion is adequate. So we always assess perfusion using end-tidal CO2, their skin color, mental status, rather than their pulse or their BP alone. Locally, VAD patients are generally managed through Mission's Health Advanced Heart Failure Clinic. They have a pretty good program. Every VAD has three parts. It has a pump, the controller, and an external power supply. Ask the caregiver where backup batteries are and where the manual is located. It's vital information during a power outage or an emergency. Make sure these patients are flagged in your dispatch system so responders know how to bring power back up and how to handle these devices correctly. Our long-term vascular access devices. So these include things like PICC lines, midlines, central lines, and implanted ports. They're used for antibiotics, chemotherapy, or nutrition. So we're going to check for redness, look for swelling, leakage signs, infection, or malfunction. In the community setting, keep the lines clean, avoid pulling or kinking, and always use antiseptic technique if you must handle the dressings. So you'll see a variety, PICCs, Hickman's, or Brovac catheters, or Portacath systems. Each one requires specialized care. Ask when the dressing was last changed and if home health is following up with them. If a line appears dislodged or the site is painful, call the supervising nurse or medical director before proceeding. Complications could include clots, infections, and mechanical failure. If you suspect an infection, take vitals, inspect for fever or redness, and notify the provider immediately. In Henderson County, many home infusion patients receive care through Option Care Health or even our Party Home Infusion. Build relationships there for fast communication. Know who to go to. It's about who you know. These pumps are medication infusion pumps. We deliver continuous IV medication, so antibiotics, nutrition, inotropes for heart failure. Ensure the device is running correctly, that our tubing isn't kinked, and alarms are addressed promptly. If the pump stops, your job is to keep the patient stable and call the infusion nurse. So we don't restart the pump without orders. Make sure you stay within your scope of practice. For these pumps, confirm they say 5 rights, although teaching paramedicine, I believe we're up to 10 rights now. So there's 5 rights of medication administration, the right patient, right drug, right dose, right route, and the right time. So CPs verify and document, not reprogram these pumps. On to trachs. A tracheostomy is a surgical opening in the neck that provides a direct airway. It can be temporary or it could be permanent. These patients are common in long-term care and home health programs across our region. Always check the stoma for cleanliness, secretions, mucus, securement, and proper humidification. You generally will see trachs after major trauma, cancer surgery, or a long-term intubation. Suctioning may be required frequently with a French catheter or flexible catheter, soft tip. Keep extra sterile catheters and saline nearby and teach caregivers how to maintain patency safely. If you notice difficulty breathing or dislodgement, this is an emergency. We're going to go ahead and ventilate over the stoma, make sure it's been cleared first, and then we're going to go ahead and call for some ALS backup. So for trachs, most patients will require an initial period of ventilator support, although this therapy is rarely continued at home. A trach affects the patient's speech as the site of the tracheostomy is below that of the vocal cords. So note the normal anatomy and physiology of the airway when looking at a trach. A tracheostomy or tubes function as a long-term replacement for endotracheal tubes. These devices are used for patients who require long-term ventilatory support, frequent tracheal suctioning, airway protection owing to a medical condition such as a traumatic brain injury, quadriplegia, or from any other disease, or ALS. Displacement of a trach tube may be an immediate threat to their life. These tubes may be placed effectively or electively in a patient's already receiving mechanical ventilation via endotracheal tubes, or in patients with a slowly evolving upper airway obstruction or a tumor. So the tube passes directly from an opening in the anterior neck below the thyroid cartilage and into the trachea. Once again, speech is not possible unless expressed air is allowed to pass around the trach tube through the larynx, which is our vocal cords. So keep in mind with suctioning, when possible, deep tracheal suctioning is performed. We may also do oral suctioning if it's required. So brush up on your suctioning techniques, what you learned back in paramedic school. Make sure you're comfortable with suctioning our trach patients. Always follow your local protocols when you are doing this as well. Oxygen therapy is one of the most common home treatments that we do encounter. Patients use concentrators, tanks, or portable units. Check that the tubing is clean, the cannula isn't kinked, and the flow rate matches the order that is set. In rural homes, confirmed backup tanks exist in case of those power losses, which are frequent issues in our mountain areas. Typical oxygen users include COPDers, CHF, asthma, obesity, hypoventilation syndrome. Pick a Wiccan. So reinforce safe storage, no smoking or open flames near the equipment. Encourage patients to check their oxygen levels regularly and report new shortness of breath or fatigue promptly. So post-surgical devices can be common in the home healthcare setting. So after surgery, patients may go home with drains or negative pressure wound therapy. These devices help remove fluid and promote healing. Always observe the color and the amount of drainage and ensure the system is sealed. If you see sudden bleeding or smell a foul odor, we do need to notify the care team immediately. So we keep count of ins and outs, so we're also keeping count of how much fluid we are taking out of these things as well as our catheters. Teach patients to keep drains below the wound level and empty as directed. In Henderson County, many patients receive wound care follow-up through Advent Health Wound Care Center or Four Seasons Home Health, so work with those teams for coordinated care. Feeding tubes. These allow nutrition when patients can't eat safely by mouth. Our common types would be nasogastric, orogastric, and our PEG tubes. So check placement markings, tube security, and watch for redness or leaking around the insertion side of the tube itself. Ensure feeds are given at the prescribed rates and position. The patient needs to be at least 30 degrees upright to prevent aspirating. If vomiting or distension occurs, stop the feed and contact the provider. In our area, homebound patients often rely on caregivers who need reinforcement on these safety steps. Ostomies, everybody's favorite, ostomies. Okay, ostomies provide a way for waste to exit the body when the GR, the GU tract, is compromised. Types include colonoscopy, ileostomy, urostomy. These can be temporary or they could be permanent depending on their condition. So inspect the skin around the site, look for leakage, for odor, all signs that the appliance needs attention. Common problems are infection, shrinking of the stoma, or blockages. Teach patients how to empty and clean their pouches correctly and remind them to watch for signs of dehydration, especially in the ileostomy cases. Be ready for questions on your exam about early recognition of stoma complication. Look for keywords like redness, edema, or loss of output. On to our ambulatory aids. These were big. This and then also our patient devices for moving. Ambulatory aids include canes, walkers, rollators. Check the device fits properly. Elbows should be slightly bent when the participant or the patient stands up. Encourage them to clear clutter, secure rugs at home to prevent falls. Do a safety check. Walk through the house with them and identify key things that could be a hazard, that could lead to them tripping and having an incident where they need to be transported. Walkers do require both hands and good coordination, so show them how to use it first. Move the walker first, then step forward. In our area, the Council on Aging and Adaptive Equipment Program ought to provide low-cost mobility aids for our seniors. Commode chairs are portable toilets for patients who can't reach the bathroom easily. Ensure that they are stable, that they are clean. They also provide privacy, though, for dignity for patients that can no longer get up and go. These are especially helpful for patients recovering from surgery or living in a multiple-story home where bathroom access is very limited. Our in-home hospital beds allow positioning for comfort and medical needs. Always check the side rails are secure, cords are not frayed, and that the power source is safe. Elevating the head of bed can help patients with COPD or CHF breathe easier. Keep that in mind. It's simple but effective intervention, and teach the family this as well. Some conditions require specific bed angles. For example, CHF and pulmonary patients benefit from that semi-Fowler position to ease breathing. So reinforce this to our caregivers as well as repositioning to help prevent that skin breakdown. All right, folks, we made it to the last slide. This is a big one, so bear with me, but there were several testables on the IBSC. Our at-home transfer devices, they are lifesavers for both the patient and the caregiver. They reduce those fall risks, prevent caregiver back injuries, and maintain patient dignity during moves. So we're going to break them down. All right, the first thing being our gait belts. So it's the simplest device made of a heavy canvas or nylon with a buckle with a quick release clip. They're used when a patient can bear some weight and just needs some assistance for balance or steadying during short moves, like from a recliner to a wheelchair or to the toilet. Always keep your palms up when assisting and position yourself close to the patient's center of gravity. Onto our slide boards. They're also known as transfer boards. These smooth boards bridge the gap between two surfaces such as a bed and a wheelchair. It's kind of like our short boards. So yes, our short boards or our long boards. They're ideal for patients who have good upper body strength but poor leg function. So think spinal cord injuries, amputees, or post-stroke patients. Ensure both surfaces are level and brakes are locked before sliding. Then we have pivot disc and turntables. These are small rotating discs which are placed under the patient's feet to assist with standing pivots. They're perfect when a patient can stand but can't easily turn. You'll see them used frequently with partial weight-bearing rehab patients. All right, hydraulic lifts. The manual Hoyer lift was on my IBSE exam. So these are the most common full-body lifts in a home. They use a hydraulic pump and a sling to raise a patient who cannot bear weight. They're ideal for complete transfers from bed to wheelchair or bed to commode when the caregiver is alone. You do need training on these to help prevent tripping or skin tears as well. The electric Hoyer lifts or power lifts, same concept, but powered by a battery or plug-in monitor. They're used for heavier patients or caregivers with limited strength. Always check our battery charge and ensure the emergency lowering feature works before we use it. Then our sit to stand lifts, the stand assist devices. These help patients who can bear partial weight but need help rising. The sling supports the lower back while the lifting assists them from sitting to standing. It's great for toileting or short transfers. These are common in rehab settings and are increasingly found in home care. Then we have our ceiling mounted track systems. So these are not as common in our home care, but you may have this in some settings. They're permanent or semi-permanent rails with a powered lift motor that travels along a tract. They're used when a patient is completely dependent or bariatric and space or caregiver strength is limited. Henderson County's Council on Aging occasionally partners with local contractors for installation, funding, or rental programs for these devices. Before every use, inspect the straps, the clips, and slings for fraying or wear. Always verify weight limits and ensure the correct sling type. Some are for bathing, some are for toileting, and others are for general transfers. In Henderson County, families often borrow or rent this equipment through medical loan closets run by local churches, the Council on Aging, and Four Seasons Home Health. It's a huge benefit for low-income households or temporary rehab situations. So, IBSC reminder, on the certification exam, they may test your understanding of which device to use based on the patient's mobility and safety. Remember, gait belt, that's assisting. We're steadying and assist. Slide board, we have upper body control, but we have a lower body deficit. The Hoyer or the power lift is non-weight bearing patients. The sit to stand is partial weight bearing. When in doubt, choose the option that maximizes patient safety and reduces caregiver strain. All right, guys, to wrap it up, every chronic disease we've covered comes back to the same goal, keeping patients stable and independent. Whether it's diabetes, COPD, heart failure, or dementia, our role as community paramedics is to monitor, educate, and connect. We bridge the gaps between hospital care and home life. We catch problems early, guide patients to the right resources, and make sure they never feel alone in managing their conditions. The takeaway, small interventions, a medication check, a quick follow-up, or a conversation about diet can prevent a 911 call tomorrow. That's the heart of chronic disease management, and that's all I've got. Tune back in for our next chapter. You guys stay safe and don't hesitate to reach out if you have any questions.